It's my pleasure today to introduce Paul Johnson, who's our first international visitor for the Tapper Endowed Lectures. This is, what, now the 10th or 12th? 11th, close. So Paul is from Great Britain, England. He's went to medical school at Leicester and trained in surgery at Oxford and pediatric surgery at the Royal Children's Hospital in Melbourne, Australia, and Great Ormond Street before returning to Oxford, where he spent his career. He has a lot of leadership positions there. He's the chairman of pediatric surgery at Oxford. He's the director of the academic surgery training program at Oxford, and also the director of the Oxford islet cell transplant program. He has international responsibilities as well. He's the chairman of the British Association of Pediatric Surgery Research Group and the new president of the International Pancreas and Islet Cell Transplant Association. Over the last 5 years, he's given at least 40 invited professorships and lectures on various topics about islet cell transplantation. I think Dr. Tapper would be really interested in this lecture. He was always fascinated by transplantation and the application of basic science research to hospitalized patients and taking what is known from the best of adult medicine and giving it to children. So without any further delay, I want to introduce Paul.
Well, thank you very much for that introduction, and it's a real honor and privilege to have been invited to give this lecture today. If I can just have the first slide up, please. Great. But of course, the introduction about me is really not what we're here for today. We're here to honor Dr. Tapper, and in terms of the celebration today, we had a lovely evening last night with his family. It was lovely to spend time with the family. And of course, what I'm hoping today is that we will be able to spend some time during this day today remembering those memories that you have in the audience of him. And I hope that my lecture is just worthy of that memory, but the main focus today needs to be of David himself. David, of course, was an outstanding academic surgeon. He's an outstanding leader. He's also an outstanding person. And one of the joys of giving a named lecture is, of course, that you spend time getting to know the person by reading about them, by hearing people's stories about them. And that's been it's particularly enjoyable learning about David. And particularly some of his sense of humour and his practical jokes that he played in this hospital. They seem to be very, very well known. And of course, he was a wonderful family man, and it was nice to spend time with you last night. He was, as I said, an academic surgeon, and I think for those of you who are trainees in the audience, I really have given this title from bench to bedside, because I think we want to really focus that academic surgery needs to go from basic science all the way through translational medicine into clinical program. And I'm going to illustrate by my particular area of research how I think that should be happening. And I think pediatric surgeons and pediatricians can take the lead in some of these major disease processes. I think relatively small numbers of cases that we see in certain pediatric conditions, but in terms of what we can actually add to the whole field, I think pediatrics really has a big part to play. And you see in pediatric surgery lots of examples of that. Pat Donoghue in Boston now, having spent years on the developmental biology of the ovary for a pediatric perspective, has now a major program to do with ovarian cancer in adults. And I think there's a whole lot of other realms. But the importance, of course, is bench to bedside constantly has to go back to the bench. There's this idea that you come up with a plan, you take it through to the clinical program, and then you stop. But of course, as we develop a new technique, it asks more questions of it than perhaps we had before, and we go back to the bench to answer those. And I think this is really the model that David was very keen to push forward. And of course, his interest in transplantation was particularly of interest to me as I give this lecture today on islet transplantation. So I suppose the question you may well be asking, certainly the surgeons in the audience may be asking, what on earth is a paediatric surgeon looking at type 1 diabetes? Well, I preloaded that question slightly by the final point of emphasising. I think paediatric surgeons need to be looking at major disease processes that have application for a whole range of surgical techniques. But if we look at the number of esophageal atresias around the world, necrotizing enterocolitis, are very tiny compared with the impact that we can make with some of these other disease processes. 13,000 new cases of type 1 diabetes diagnosed last year in the US, and that, of course, is climbing, and there's a lot of papers to show that in Europe particularly. And, of course, primarily it is a condition of pediatric onset, and this is really where we need to tackle these novel therapies. And of course, you know, I know that the diabetologists in the audience may not completely agree, but actually if you look at some of the most exciting new therapies, they are in fact surgical in the broadest range of that word. And finally, I would say that of course the blurring between surgery and medicine is narrowing every year. We're going increasingly for minimally invasive surgery to get rid of the old-fashioned approach to major laparotomies, etc. And of course, the interventions of radiologists, etc., are coming closer and closer. And I think we're talking about very combined fields if we look at medicine in the next 10 to 20 years. So just before I get on with the main part of the lecture, just a quick disclosure. I do sit on 2 scientific advisory boards of relevance to this talk, but I'm not going to be mentioning any of the actual work there, so there's no conflicts of interest. So that's my disclosure slide, which I know that is important in this country. So the outline of my talk today is as follows. I'm going to start off by just explaining a bit about the rationale for islet transplantation. For some that will be completely old hat, for others it may just be new, but it's important to set the scene before we discuss islet transplantation in more detail. I'm going to show you and talk you through just some of the methods so that can be visualized and understood. I'm going to highlight the current results, particularly emphasising this bench to bedside, where we were 20 years ago or 15 years ago, is a very, very different place from where we are today here in 2012. And finally, I want to touch on the current challenges and where I think the young minds in this audience, if they really want to pick some of these themes up, can target their research efforts and their clinical efforts in order to move it through to children over the next decade. So the rationale for islet transplantation, if we're talking about any new techniques in diabetes, it's vitally important to really ground ourselves on a memory of the incredible discovery of insulin back in the 1920s. And many of you may know the story, but it's well worth reading if you don't know it. The discovery of insulin by these 2 guys, Banting and Best together, and MacLeod in the laboratory, is a fascinating story. It's not just a fascinating story of science, but those who don't know the story, it's a fascinating story of intrigue and where science and competition can actually often almost disrupt discovery. And I think it's a really prudent lesson for the juniors to learn that, yes, we need to be trying to push frontiers, we need to be finding new discoveries, but you need to do that in the context of working with people and having respect for people, etc. So it's a very, very interesting story, ending up with an air crash of some mystique to it. But nonetheless, the discovery of insulin transformed the disease process, and there are lots of pictures throughout the textbooks here on the left of children who were wasting with the disease, who then, after 6 months of insulin in this example, suddenly actually were able to survive the acute onset of the disease. But one of the things with any medical discovery, of course, is that we develop problems for ourselves further down the line. So we turned a relatively incurable disease into a curable disease in the acute onset. But of course, now the major problem with type 1 diabetes is the long-term complications, which form a major source of mortality and morbidity, and also a major source of healthcare resources. So if we're talking about how to treat these, then of course we need to understand why they develop. And it's true to say, and I haven't got time to go into a lot of detail, but the secondary complications of type 1 diabetes are multifactorial. Some children and teenagers will start to see changes, and others don't with exactly the same level of control. But I think we will all agree that there is a clear relationship overall between tightness of glycemic control and onset of complications. And this is just one of the major studies, but there are a number since and smaller studies since. The DCTT trial, which here in Seattle, you took part in that in the adult practice. Intensive versus conventional insulin, 1,441 patients from 29 centres around the US and Canada. Follow-up mean 6.5 years. And it was meant to be an 8-year study, but it was stopped because of the overwhelming findings of improvement with the intensive treatment at the same time as severe hypoglycemia with that intense, with some fatalities. But the overall take-home messages from that was intensive therapy reduced retinopathy risk by 76%. That was in those who had no retinopathy to start with reduced gross albuminuria by 54%, and intensive reduced clinical neuropathy by 60%. And these findings were really overwhelming. They weren't groundbreaking in the sense that that was really presumed, but it was the first time it had been clearly demonstrated in a large cohort of patients. And the diabetologists in the audience, we can go into the critique of that. There are some flaws in the study, but nonetheless, the take-home message is and was and is that that glycemic control and the tightness of that does improve your chances of not getting those long-term complications. So if we were to set goals for an ideal treatment for type 1 diabetes, it would be some of these factors would come into it. We first of all want to restore normal glucose homeostasis. Now that is distinct from just suppressing the highs and the lows. We want to really re-establish that minute-to-minute, second-to-second variation. So those of you who have just had breakfast and who are falling asleep during the talk, your insulin would have switched off. And then when I mentioned that, you'd have had a little pulse of insulin in a sudden response. Well, you may not have done, but most of you will have done. And so what we have in the normal pancreas is a very, very fine mechanism, which of course is not only insulin, it's somatostatin, glucagon, and all the cycle of the different hormones having their paracrine influence on one another. And that happens throughout the 24 hours rather than just during the daytime. And it's more than just suppressing highs and lows. The second thing is we need to find a treatment that we can use in childhood before the horse has bolted, as we would say in the UK. So in other words, rather than waiting till the complications are developed and trying to go catch up, ideally we want to treat this early in the onset to prevent those complications. And the other thing is we need to have a treatment in which the morbidity and mortality of the treatment are of course less than diabetes itself. There's no point in having a treatment that itself causes more complications. So how can we do that? Well, there are intensive insulin regimes. We've touched on that in that trial. The real problem with that is hypoglycemia, life-threatening hypoglycemia on the truly intensive regimes. And of course, if you're looking at childhood, I mean, I speak a lot to children's groups in the UK. And of course, the one thing that the parents are struggling with, not so much whether these children will have retinopathy 30 years down the line, but actually the fight every day of the week to inject their child. Intensive insulin regimes doesn't exactly help that. We have insulin pumps. They get more and more refined. You remember the very large ones that started off almost filling the room, and now they got smaller and smaller and smaller, and very, very well tolerated. Again, the one problem in terms of our ideal aim of treatment is that these pumps are still mechanical, prone to particular mechanical problems from time to time, and you are still relying on exogenous insulin, and you're not getting back to that feedback, the minute-to-minute ideal variation that we're trying to get to. So a third option is to transplant the insulin-producing tissue. And that, by doing that, you can transplant it either in a whole pancreas, bearing in mind that a pancreas is only 2% islets, and the rest of it is exocrine tissue, or you can take the islets, extract them, and inject those in a minimally invasive means. Now, the whole pancreas transplantation, just to summarize that, first transplant done in Minnesota back in the 1960s. Their success rate wasn't great. I mean, most programs would have been closed down if we produced these figures today. Here you can see the survival, and here you can see the cause of death. So the vast majority of these died soon after, and the vast majority of them were dying because of sepsis or because of pancreatitis, mainly caused by the exocrine leakage, which again is ironic in the sense that they didn't really need that exocrine component. Now, that has changed enormously, as you all know, and maybe people in the audience are involved or have been involved in whole pancreas programs. There have been technical advances, and there's been advances in immunosuppression, so much so that this is now the, although these are previous figures sent to the international registry, they still hold true today, and this is the latest report from that particular register. What we have here is we have a pancreas insulin independence rate, a pancreas graft survival of 85% at 1 year. Most of the patients in this group were having kidney at the same time, and this is the survival of the kidney. And the patient survival is 96%. And those figures still hold true in terms of the mortality. Now, I guess when you look at that 96%, it depends whether you're a glass half empty or a glass half full type of person. It sounds impressive, but for the surgeons around here, that is a 4% mortality. And if you're talking about a child with relatively new onset diabetes, that really is a complication rate that we cannot support. My colleagues in Oxford on the whole pancreas program have a very successful program, now one of the largest in Europe, and these are their latest figures. So this is a simultaneous pancreas kidney, 89 or nearly 90% survival at 1 year of the graft. Pancreas transplant alone slightly less. I get you to hold that figure, sort of 75 to 80%, because I'll come back to that when we talk about islets. But again, the patient survival, there is a mortality rate, there is a high operation rate. So I think my conclusion with whole pancreas is it's very successful in young adults who need a kidney and who you want to guarantee coming off insulin in a more ready, predictable manner at the moment. But it's never going to be an option for children. It's not the one that we should be aiming to target for children, because it is still a major procedure by any comparator. Islet transplantation, on the other hand, and here we see the two therapies compared, is a minimally invasive procedure. You are conceptually, I think, improving it by taking just the tissue that's at fault. You have the same potential, and I use that word potential, I think it's now become a reality as well, but the same potential to restore normal glycemia. But you also have this additional advantage that we have potential strategies we can use to, in order that in the future we won't need to use immunosuppression. And that's the crux if we're going to apply this to children, not just the initial operation, but the long-term immunosuppression, which of course is associated with the morbidity and indeed in some cases mortality. So I've deliberately spent some time bringing us up to the rationale, because I think it's an important first step to talk about. And now I want to talk about the actual methods that are used. The challenge of islet transplantation is not so much the transplant, that can be done in many hospitals, it is the extraction of the islets. And the challenge is to keep those islets intact rather than breaking them up into single cells, at the same time as separating the surrounding tissue. And if we look at this schematic, the pancreas is donated, it comes into the laboratory. We then put it through processes of breaking it down with a mechanical and enzymatic dissociation. We then digest the pancreas with the enzyme inside, and I'll show you pictures of these in a moment. We then take advantage of the fact that we have a pancreas digest made up of separated islets with the tissue, the exocrine tissue, but still sitting together here. And then we make use of the fact that islets are less dense than their exocrine counterpart and put it on a density gradient separator, which separates the islets because they're lighter or less dense, and the exocrine tissue, so we can get pure islets as a result of that, and then we transplant it. So those are the two stages. The challenge, as I said, is to keep this sort of 2,000 to 5,000 cells within this ball of cells. We need to keep that intact. We need to separate the exocrine tissue here. It's very easy to get beta cells out, but in order to keep the islet as a mini organelle, that's where the challenge lies. The other thing that's changed, both here with the FDA and in Europe with the European guidelines, the European guidelines are restricting almost everything we do from day to day. Just as an aside, I was talking to your fellows this morning. We're now restricted to 48 hours a week for all our trainees. They're not allowed to do more than 48 hours a week in any discipline. So our hospitals get fined if they're in for longer. They have to be off if they've been on call the night before. The whole thing has gone crazy. So you're 80 hours a week. Just relax and enjoy it. 48 hours a week is untrainable, particularly as we haven't extended our length of training. But we can talk about that later on. But the other thing that European guidelines have made is that we used to do this extraction. I've done this for about 25 years. We used to do it in an ordinary laboratory during the night, shaking this chamber in ordinary lab coats. Often people would be eating a pizza at the same time as doing it because it was 2 o'clock in the morning. All that has gone. The Tissue Act has come in, and we've really got very, very tight restrictions. So this facility we now have in Oxford is one of only a few in Europe. 1.2 million to build it. It has 4 levels of cleanliness of airflow, and it's like something normally you would just see in industry rather than in the field of science. This is our central room where the work goes, but we designed this so that we can actually monitor it all from this glass screened office, and all the microscope images go through to there so that the whole thing can be monitored. But it's a nice facility, but it's very much more complex than the simple days of the 1990s. The pancreas retrieval, multi-organ retrieval like any other organ. The donor age has shown. Cold ischemia time we try to keep less than 8 hours. We try to keep a BMI less than 40 if we can, and we obviously important there's no relevant past medical history to do with the pancreas. Now, interestingly, when you look at these 2 fine specimens, when you look at David Beckham here, or the fine American example compared with the British chap here, or is it the other way around? I'm not sure, but at the end of the day, the reason I show you this slide is because there's a lot of literature in this area, if any of you are involved in this, to show that, or to suggest that the ideal islet for islet transplantation comes from this fine specimen here. Now, the confusion is that it's much, much easier getting islets out of that sort of donor, but it's not that they're ideal in terms of physiology. I think if it was myself having a transplant, I think I'd definitely want a pancreas from this better specimen here. Now, that's shown very clearly in this study from Edmonton. If we look at here, we have donor age, the range of ages here. We have the isolation success here, and it's certainly much easier to break down the older matrix of the pancreas. The islets fall out, compared with this younger group, which really it's quite hard. This is percentage success, this is the donor age. However, if you then look at the insulin secretion from these cells, you see an inverse relationship, not surprisingly. And that's really the current challenge of islet isolation. We can easily get islets out of the out of the pancreases that we ideally don't want to use. And that's really giving us quite a lot of scientific headaches, I should say. And of course, it's shown in other aspects. You look at PDX gene expression, you look at apoptosis rates. Again, they all show, as you might expect, the older the age group, the worse the islets. So we get ideally an optimal pancreas. We then will then take that pancreas and we cannulate it and we infuse it with commercially available bacterial collagenase. This is the sort of pancreas. For those of you who are not medical in the audience, there won't be many more pictures putting you off your breakfast, or bringing up your breakfast, I should say. Here we have the pancreas arriving with the spleen attached, the duodenum attached. This looks like it's from that fine specimen on the right, actually. And we clean the pancreas. We put a catheter up the pancreatic duct, having cleaned it, and we then infuse it and distend the pancreas with this collagenase. Now, the collagenase, as I said, is from bacteria. It's a Clostridium histolyticum type of bacteria. The problem is, again, is that these products vary from batch to batch to batch. And again, it's a very unpredictable process, as I'll just allude to in a couple of slides at the end. But nonetheless, here we are. We cannulate the pancreas. We then infuse it with a reperfusion device. And what you're doing essentially here is sending the collagenase up the pancreatic duct into the little ductules so that you then deliver it to the interface between the islet and the surrounding exocrine tissue. The pancreas, after it's been distended, is then chopped into pieces and is then placed into this device with a chamber in the center which has ball bearings in the center. So you've got mechanical dissociation working on a pancreas that's distended with enzyme. And then you have a heating system, you have various solutions bathing around, and I won't bore you with the rest of that. Every few minutes during the digestion, we then monitor it by taking a sample. We make use of this dithazone dye that stains the zinc granules in islets red, and here's a nice islet that's been cleaned of exocrine tissue, and here's the exocrine tissue here, and here's an islet that's still attached to exocrine tissue. Now, the important thing of monitoring is you want to liberate these islets because the next stage relies on the different densities. And if the islet is still part of this, it's the same density as that surrounding tissue rather than this. So therefore, that will be lost when you go for your density gradient. Okay? Now, at the end of digestion, you're left with here pancreas soup, really, and here's the pancreas with the duct, and really most of it's been digested away. The next stage is the separation, and we now push forward perhaps about 3 or 4 hours, and here you see the digest going onto a cell separator, which contains this density gradient, and just like sticks and stones being thrown into a pond, the sticks float, the stones sink. It's a very similar analogy for the non-medics in the audience in terms of being able to get the islets like the sticks and the exocrine tissue sinks. And what we reduce is the volume of, say, 20 to 50 mils down to less than 5 mils and get rid of the other tissue, and we have some nice pure islets that can be ready to be transplanted. The islets are then put into culture. We used to transplant them fresh, but now culture adds a lot of advantages for a number of different reasons. First of all, logistically, we can get our patients in from distance without having to bring them in the middle of the night and get the islets straight in. Secondly, it enables us to quality test these islets to ensure that they really are as good as they look macroscopically. And thirdly, we can actually consider patient pre-treatment and various other aspects of the transplant regime. We do a whole range of tests on these islets before we put them in. This is an example of static incubation. Here we stimulate with glucose. We then put a low glucose, lower, and then high, and see the stimulation. And you can see the response showing that these islets are actually functioning very nicely. We then have strict product release criteria. And in Oxford, we not only provide islets for our own patients, we actually have a service that we send them out to 6 centres around the country. And in North America, you have a few similar type of networks where islets are being isolated from one place and then sent to another to be transplanted. And that's, I think, the most efficient way of doing it. We then have the actual islet transplant itself. The islet transplant, most of these are done either laparoscopically or percutaneously. You try to do the percutaneous approach first under radiographic control. Otherwise, you do a mini laparotomy or a laparoscopy. And the essential thing is that we put them in the portal vein and they then infuse up into the liver sinusoids. Now, we can have a long debate about whether the liver is the right place to put them, but it's certainly the most accessible. It has a large blood supply and it has its sinusoidal network, which means the islets get trapped rather than end up going around the rest of the body. We give antibiotic and heparin cover. We highly heparinize these patients, and we infuse the islets over probably about 20 to 25 minutes. I've been a bit optimistic with 10 to 15. And the role of the surgeon at this point of view, if you're not doing laparoscopy or laparotomy, is to hold the bag, because in the UK we're running out of drip stands, and that's actually one of the roles we have. The important thing, however, is to monitor the pressure within the portal vein very, very closely to make sure that you're not getting any rise in portal pressure. Now, if you've got pure tissue like that, the chance of portal vein thrombosis is really minuscule, and we haven't had a single reported case. However, if you use impure tissue, as people did back in the 90s, that is a potential risk, and therefore we still monitor very closely, even though now the amount of tissue we're putting in is really minuscule. This is showing across the radiographic control. Here we have the catheter coming across. Here's the portal vein, and here's the portal tree. So we monitor the infusion. Now, I said the liver is the one we use. There have been a whole lot of alternative sites proposed. Certainly, in canine models, the spleen has been shown to be an advantage from an immunological point of view. There is difficulty doing that percutaneously because the access to the spleen is harder, and you can blow up balloons and stop it refluxing. But the real issue is that they mostly end up in the liver anyway if you do that. So the spleen theoretically is a good site. The omentum has been used. Kidney subcapsule, again, experimentally we use that. It's really not very accessible in the human subcapsule. The testis and ovary, when I speak to patient groups, they always wince at this bit, as I probably do when I talk about it, but it's Memphis that's actually pushed that quite strongly. And again, it comes back to the immunology. It's an immune-privileged site. And therefore there is an advantage in terms of rejection. The problem is to get them into the testis, you end up breaching the capsule and you then lose that immune privilege. Plus, actually, when you volunteer this to patient groups, they don't put their hand up very readily to be the people who are going to try it out. So I think, again, it may well be more theoretical, although we are looking at all sorts of different sites at the moment to try and improve the outcomes. The other immune privilege site is the eye. If you use that, you certainly see floaters, and it's not really the way to do it in a clinical context. Experimentally, again, it is a useful site to monitor things. After the transplant, the most important thing is to let those islets establish their blood supply, eventually establish their nerve supply. Fascinating, when you look at them 6 months later and take a biopsy, they have re-established their full mantle of blood supply. You remember from your anatomy, the blood supply around the islet is a complex mantle going from one cell to the other in a very ordered manner. That is fully re-established by 6 months after the transplant, as is the autonomic nerve supply. But the important thing is for the first 48 hours, we want to make sure those islets are completely rested. And so we put on a very tight sliding scale. We make sure that we really don't get those islets to work until at least 48 hours afterwards. And then we put them back on their pre-transplant dosage and then start to wean it off over the next week or two as the islets kick in with their insulin secretion. There is a very intensive outpatient regime for the first month or two. We see them twice weekly and then more often if they've got issues. And then we do, I should say, we always do a liver ultrasound at 24 hours just to check the portal vein is flowing and there's no hematomas or other sequelae. So that's really just showing you and illustrated what we do from beginning of it to the end of this procedure. And now I just want to really summarize where we are with the results, emphasizing, I think, how far we've come from this bench to bedside manner. Back in the 70s, 80s, 90s, in rodents and indeed in canine models, it was possible to reverse diabetes every day of the week routinely without any problem whatsoever. The transition, however, from that into the patient situation was a somewhat frustrating and slightly more delayed process. There are a number of different developments, but these have been very piecemeal rather than being suddenly a eureka moment. It's been very much a series of improvements, and we are still improving with different regimes as we are. But one of the key improvements was this so-called Edmonton Protocol. That was really in 2000. I would say if you had to have one major change, even if there was no major discovery, that would have been it. And that really turned it from a very successful rodent procedure to one that actually is now very successful in the human context. These are the results pre-Edmonton in the human trials. There were 493 procedures in 40 institutions, so this isn't a new procedure. But actually, when you look at the success, only 11% achieved insulin independence. Now, there were some individual successes. We knew it could work, but the frustration from what we could do in the lab to what we could do in the clinic really was quite major. These are the Edmonton, the Oxford 9 in this pre-Edmonton series. This is C-peptide or insulin production versus time. And you can see some patients had no insulin secretion, others had variable secretion, but none of these patients actually came off insulin back in the mid-1990s. And then the Edmonton Protocol, published in the New England Journal of Medicine, 7 consecutive patients that came off insulin with the age ranges as I've shown. And they currently have an 80 to 85% insulin dependence rate at a year, and I'll come back to those results in a moment. What was it that Edmonton did differently? I think if you're describing it as a piece of science, it was somewhat frustrating because they changed so many things slightly, and it was impossible really to put your finger on what it was. And when you speak to James Shapiro, who headed that program, I think even he doesn't really know which was the key factor. Although steroid-free immunosuppression definitely was a factor. Most of the patients in the 90s were having a kidney, and we know that steroid is pretty harmful to islets, so it was steroid-free. He gave every person a transplant at least 2 or 3 in quite quick succession over a period of 3 to 4 months. Again, that probably made a difference, giving lots and lots of islets. Unfortunately, we haven't got the luxury of that many pancreases per patient with diabetes, and so we now know that we can get the same results on a one-to-one basis, as I'll show you in a moment. The group of patients was different. These patients had normal renal function, and they had life-threatening hypoglycemic unawareness. So these are patients on maximal medical treatment who had then life-threatening hypos, at least 2 episodes in the previous 18 months that required third-party intervention. Again, was that the answer? Well, we know that that's the main indication we use it for now, but we've also got similarly good results in patients who have a kidney graft or patients who are having a hip kidney graft at the same time. So it can't have been the full explanation. This, I think, illustrates from Geneva the difference where we're going from this bench to bedside. Here in green you have the current era, and here you have the previous different decades as shown, or different groups of decades as shown. And this is C-peptide production, or insulin production, and this is insulin independence. And you can start to see a huge improvement between 2008 and 2012 compared with the 90s. And this could be replicated in series around the world. The one problem about the Edmonton Protocol, however, was that we got very, very good one-year results, and the cynics then said, yes, but let's watch for the 3- and 5-year results. And of course, they started to tail down. Like, if you look at the history of transplant overall, that's happened with nearly every organ that's been developed. So those of us in the field thought, yes, but just wait, that's going to level out. The rest thought, that's great, islet transplantation's here and gone now, it's not going to bother us anymore. But actually, the current data would suggest what we originally predicted, that the 3- and 5-year figures are now replicating those of other organs. And if you look at, this is Minneapolis, and this is a particularly subgroup series, it must be said, but this is pancreas transplant alone on the left. This is 1 year, 3 years, 5 years. And here you see the islet transplant program. Now, it's a small group, and so there are potential problems with this. But by and large, I think this theme is being reproduced in a lot of different centres now. And this, I would say, was the best figures around. It's not the all-comers, but it's the best. But it's what can be achieved in 2012. Here we have very similar figures, no statistical difference between here and the 3-year figures, and the 5-year figures are similar across the board. So in terms of the comparison with whole pancreas transplant, I think really the parity of the two therapies is really starting to really even out. We look at the original Edmonton protocol. They changed their induction immunosuppression to Campath, and their Campath induction seems to have made a big difference. Here we see the original Edmonton protocol at 5 years, 15% was still off insulin, whereas now with the Campath it's up to into the mid-60s, and their overall insulin dependence rate for the all-comers, 74%. So these figures really are starting to look very encouraging and very impressive. And I think that islet transplantation really has come of age in terms of a select group of adult patients here in 2012. I said it was important to get it a single donor. Minneapolis probably got the best results again. This is the single donor experience, which of course, for whole pancreas comparison, we can't be using 3 organs when they're only getting the same results with 1. So for parity, 1-to-1, and in certainly these 20 patients, very similar results. Now, the main reason we do this, however, is not insulin independence. It is to get tight glycemic control and, more specifically, to resolve the life-threatening hypoglycemia. And this is the CITR, the US registry. This is looking at the pre-transplant life-threatening hypo rate versus the 3-year figures in terms of severe hypo episodes in dark. And again, this procedure is very, very impressive for life-threatening hypoglycemic unawareness. In Oxford, we only have a single patient who has not resolved that, whether they come off insulin or not. And we are only taking patients on who literally have life-threatening hypoglycemia, they're housebound, etc. A lot of them are very young patients with young children. And so I think for this role, it's a very minimally invasive way to achieve that very impressively. We also now know from some excellent work from the group in Vancouver under Garth Warnock that if you compare islet transplant with medical treatment, which is the comparison indeed following up from the DCT in many ways, the equivalent, they're starting to see improved metabolic control in the islet group, this is HbA1c, compared with the intensive medical treatment. And that is translating into renal function improvement and also into microangiopathy in terms of retinopathy. So I think we're starting to see that intense control is having an impact down the line on the very complications that we're trying to either stabilize, reverse, or prevent. Now, in the UK, we've now got to the stage where our government has set this up as a National Health Service procedure. Any patient in the UK who has this, the indications, can have this as a free treatment, but at the moment, we've limited to over the age of 18. The isolation is done in 2 centres. We've got London and ourselves on a 1 in 2 alternating, and then all of us, these centres listed here, then receive islets to put into our patients with a combined UK waiting list. NICE, which is our government body that monitors health procedures, has given us these 2 parameters to monitor. Resolution of life-threatening hypoglycemic unawareness. There is a significant mortality on the waiting list with this condition, and stabilisation of glycemic control, which of course links to the complications. If we achieve insulin independence, which we are in 70–75% of our patients, they like it, but they're not funding it to monitor that particular output. Here we see that the first 12 patients, severe hypoglycemia, completely resolved at 12 months in all the patients. This is the first 12 patients, and then here we see the pre-transplant HbA1cs followed by the 12 months figures, and I'll show you some examples. I just want to give you a few examples of some of our patients. This is a 45-year-old lady. She had 2 young children. She couldn't leave the house because her children wouldn't go with her, because each time she went to the park with them, she ended up in hospital. And the problem was, this is showing her each of these is a day's worth of glucose readings, and you can see they're all over the place if we look at the range we're trying to control. Her HbA1c was high at 7%. We then did the transplant. She has had insulin. She's in insulin dependence for 11 months when this slide was taken. Her HbA1c is back in a very normal or hypernormal range, and she has a very tight control with none of those hypos. And what's very interesting, within about a month, if patients do get hypos, they get the awareness back like they had when they were first diagnosed. It's really very, very impressive. This patient here, this patient is now 2 years out. This is an old slide because I wanted to show the glucose monitoring, but he's now 2 years off insulin. He likes his story to be told, so I'm not breaking any confidences, but this guy here didn't know he had hypoglycemic unawareness. He mounted the pavement and killed a 4-year-old child when he was out in his painter and decorator van, and was, as a result of that, was sent to prison for 4 years. We had an appeal because the prison sentence was based on a so-called expert witness who said there was no such thing as hypoglycemic unawareness. When I looked at the so-called expert witness, he hadn't done diabetes for 15 years, diabetology for 15 years. But the bottom line is he was sent to prison. People wanted vengeance because it was a 4-year-old child. We appealed, we got him out, we transplanted him after about 4 months in prison. And he has been off insulin for 2 years. He has tight control, and he's just, again, applying for his license again 2 years later with his life back intact. This is a girl who's got similar results. Again, HbA1c, you see the differences. You see a very tight control here. She's still on a smidgen of insulin, but basically because she won't let us stop it. She insists on having 4 units a day just because she feels better on it. So unfortunately, we can't report her as an insulin dependence, but she's had a very, very good result. On the other hand, this lady has only had a 40% reduction in her insulin, so she's still on 60% of her requirements. But when you actually look 18 months later at her meal tolerance test, here she had no response from, this is glucose here and C-peptide, and again, 18 months later, she's still mounting a good response, even though she's not of insulin, and she's not having hypoglycemic episodes, life-threatening. So again, not insulin dependent, but she has met our government criteria and indeed some of the worldwide criteria for success. And we can send islets out. This patient's now been off insulin for 2.5 years, and again, tight control from islets, which we extracted in Oxford, as I've shown you. So our current selection criteria as follows. Type 1 diabetes for more than 5 years. Our age limit is 18. We're not allowed to have an upper age limit because it counts as ageist in the UK now. So that should really, I need to modify that slide to 16 to 120. But it's if they've got comorbidity. So you can have comorbidity in an 18-year-old, and you have comorbidity and no comorbidity in a 70-year-old. So we are transplanting up to the late 60s, early 70s. I think it's our oldest patient. The first priority is recurrent hypoglycemic episodes, and the second priority is an established renal graft with uncontrolled diabetes, despite optimal medical therapy. That's the key bit. Optimal medical therapy is still the #1 target, and if that has failed, then we then can go on to an islet transplant. And I think this is a really important thing to hold in your mind the whole time. The complications of diabetes versus the complications of immunosuppression is really what we're weighing up on every single patient we have. If you're 42 and you've got life-threatening hypoglycemic unawareness, you can't leave the house, then actually this is grossly outweighing your complicated immunosuppression 20 years down the line. Whereas if you're a young child at the moment, that is a reverse swing. So that's brought you up to date with the rationale for why we do it. It's brought you how we do it in the methods. It's brought you the results of where we are here in 2012 from the bench to the bedside. But of course, as I said, we now need to go back to the bench or certainly in the translational medicine to be able to take this further now in order to be able to apply it to this young child here. There are three main challenges I want to just close with. The first is the isolation procedure is very variable. The second is that even if it was perfect, the number of donors is still too small for the number of patients requiring this, so we need an alternative source of islets. And finally, we have the immune challenges. Immunosuppression is all very well. It keeps away the autoimmunity. It also largely helps the alloimmunity, but still we can't have that long-term in children because of the toxicity. So variability of islet isolation, there's a complex interaction between the collagenase and the pancreas. Of course, the pancreas has many enzymes itself, collagenase has many different components, and the whole biochemical milieu is really quite complicated. The key to it, though, I think, is to understand the matrix at an ultrastructural level for different donor groups. At the moment, we use the same procedure, whatever the donor, whereas we're now looking at targeting and understanding in great detail the actual ultrastructure of the pancreas. This is an electron microscope picture, 45-year-old female donor. This is the islet exocrine interface, this gap here, and each of these is a collagen fibril. And you can see very loose fibril in this particular 45-year-old. But then another donor, another week, here's a 45-year-old lady as well, dense fibers of collagen. And again, we need to have some way of predicting that and then targeting specific enzymes. And we're working with the companies to try and relate that to structure. We're also looking at actual delivery. I showed you that delivery technique we use. Quite surprising to us was when we analysed its distribution within the pancreas, one of my postdocs, Sarah Cross, found that actually in the vast majority of cases, collagenase here in green, and here's the islet in red, is actually entering the islet during the methods that we use. So we're trying to refine that. We're doing some functional MRI imaging of the collagenase going in, etc., etc., etc. But even if we get that perfect, as I said, we need an alternative source. And most of the work is going on these two sources, either a xenogeneic source, using animal islets, particularly the pig, or islet stem cells. Of course, stem cells are the cure for everything. And they're being proposed in all sorts of ways for islets as well. I think for the xenogenetic tissue, we're a little bit away from here. I think we're not quite at the stage where you can go to your butcher and decide whether you want it for transplanting or for cooking. Nonetheless, I think in the next 2 years, you will see in the US pig-to-human trials being conducted, probably in Minneapolis. They have done some outstanding work on non-human primates, showing some really good success rates. There's a whole project called the Spring Point Project, where the pigs are being produced, which are in this clean environment. They've even got a pig source that secretes immunosuppression from around the islet. And there's some really, really very clever work going on. So I think the regulatory bodies are paving the way both in Europe and US, and I think that really will be, those trials will go ahead in the not too distant future. That is really a huge leap from the bench to the bedside. The islet stem cells, of course, that's not the role of going into that in too much detail now in the last couple of minutes, but what I think I want to emphasize is that this doesn't just have to be embryonic. Obviously, the iPS cells has opened up a whole new avenue, as has the amniotic cells. Some of the interesting work's being done in redirecting adult stem cells. Of course, the origin of islets comes from the same foregut source as the liver and the bile duct. And there's some very nice work taking liver biopsies and then sending them down a pancreatic lineage and producing islets out of that. We've been involved, the dogma is that the embryonic epithelium provides all the cells and the pancreatic mesenchyme does nothing apart from providing signals. And we've questioned that dogma, like people did with the kidney a number of years ago. And we have shown, certainly in an avian model using chit quail chimeras, that you can actually develop islets from mesenchymal tissue. And we've gone on to be able to confirm that they also express the master gene. It's not just an artifact. You really do turn them into proper pancreatic cells. and also that actually you get true downregulation of the mesenchyme rather than just cross-linking. So I think there are all sorts of different areas that we can start to look at in this area, but it's a very interesting area. And for the pediatric surgeons or pediatricians in here, developmental biology really is the key basic science behind that. But finally, we have the immune challenges, and they are not, they cannot be minimized. There are two approaches to these. You can either isolate the islet from the immune system so the immune system can't attack it. And you can either do that in little tiny alginate capsules, as you can see here. These are little islets sitting within an alginate bubble. And the insulin can be secreted through the pores of this bubble, and the blood can bathe it, but things like macrophages cannot get into that bubble to protect it. Again, a nice concept, maybe slightly simplistic in terms of the smaller molecules can get in there, and the other problem is the biocompatibility of the alginate, but it's a nice concept. It's one that is being investigated very heavily, and in fact JDRF are putting a lot of their money into this in their latest rounds of funding. We're involved in, rather than the microcapsules, looking at macrocapsules. This is a credit card size sheet of alginate that you embed islets in. It's got a portacath to it. You can then replace islets. You can then put new islets in. It goes under the abdominal wall, and then you can take that little credit card out when the islets have fatigued or failed and put another one in. So again, I think that's another area that's going to be explored, and this is just another example of another related product. And then the other side of the coin is not isolating the islets, but actually getting immune tolerance. And there's all sorts of protocols being looked at with Treg cells of these donor antigens, super antigens being clonally deleted. And again, that's the other side of the coin, which again is a very exciting area. So I've taken you through rationale, taken you through what we do, taken you through the current results. And I hope I've inspired some of the younger people in the audience to pick up some of those other challenges so that we can move it through to children. Islet transplantation works well. We've known that for years in the lab. We now know it in selected patients. We want to make it much wider available. There are a number of challenges, and the immune challenges, particularly for the child. I don't think we can do it currently with immunosuppression unless there's a teenager with the same indications of hyperglycemic unawareness. And the other thing I would say, if you have nothing to do with islets or nothing to do with diabetes, these techniques can be applied to a whole host of diseases, myocytes for muscular dystrophy, hepatocytes for liver failure, a whole range of tissue engineering of artificial small bowel, etc., etc., etc. And I'd really encourage you to get excited about this whole area of medicine. I'm also finally aware that it's very easy for me to be standing at the front while all my team are back at home doing the hard work. And so I want to acknowledge, and this is the team who are doing the hard work. These are our funding bodies. And finally, I'd just like to thank you for giving me this opportunity, and I hope it's been a worthy tribute to David, and I hope the rest of our day will be able to focus on David and his memory. Thank you very much.
That was an excellent presentation. Certainly brought us up to date with this field. My name's Jorge Reyes. I'm the transplant surgeon here. And I'd like to know what your immunosuppressive protocol is and what your maintenance long-term for these selected patients is, because, again, the key here, at least later, would be maintenance or not of immunosuppression.
Yeah.
That's a major stumbling block.
Yeah.
And the example of that is that auto-transplantation works pretty much routinely because it's a single infusion and there's no immunosuppression. So could you give us your insights as to...
Certainly. I'll just come back to that last comment. The autoimmune situation, as you say, is very predictable if you can get enough islets. But the insulin dependence rates are pretty low compared with allotransplantation, because by the time you do a pancreatectomy, then actually quite a lot of those islets are already fatigued. So that, I mean, it is an interesting area. But from the immune side, we use CAMPATH induction is our standard regime, and then we use tacrolimus and MMF as our maintenance. And for the first 3 months, we like to maintain our tacrolimus at 8 to 12 as our level, and then move it down to 5 to 8 after 3 months. So that's...
And do you have a tolerance monitorization?
We do have a monitorization, but we've got no patients who are tolerant at the moment in terms of being off. We have, however, got Catherine Wood, whose whole lab is based on tolerance, and she is doing some trials of Treg in kidneys. There's a trial going on in Europe of kidney transplants and Treg, and the plan is to perhaps push that on to islets in the next few years. but at the moment we don't. They're on maintenance therapy, and 3 or 4 years later they're still on maintenance therapy. Yeah. Okay.
Dr. Johnson, excellent presentation and great work. This is very exciting to hear. What's different about people who have severe hypoglycemic unawareness? Diabetes is just hard work for people who have it, and some are very successful with it and some aren't. But is there something different about those people who don't recognize it? Are they just sloppy with their blood sugar testing, or is it something else?
So I think the first thing is, I think they may develop it by being, a group of them might develop with a sloppiness, but I think we're talking about a group who have had really tight control. They've been referred by diabetologists who've been working on tight control. So these aren't the group that are just out of control coming to us and we stick islets into them. We are very, very strict about who we'll take on. They have to have gone through every effort to get them as tight as possible, and with them being tight, they have still lost their control. So I think that's the first thing to say. So I don't think it's just a lack of control. Quite what it is, though, that gives such a ready reversal of it, I think is questionable. We see 2 peaks. We see in the first month a resolution. If they get a hypo, they get warnings of it very early. And then at 6 months, we see kicking in of an even more refined response rate. And our theoretical, what we're working on at the moment is that at 6 months, the autonomic nerve supply does have a factor. But to start with, it's probably we think it may well be glucagon response. So we think that's why the beta cell transplants don't have that same effect in the small numbers that have been done, that actually the glucagon response and the islet together seems to be crucial for that. There's another group of people who just say that it is that you get even tighter control than you could with the medical treatment, and therefore they detect their hypos because they're in that tight band rather than the swinging band that you see. But I think it's a good question. Are they a completely different group of patients, or have they got to the point of no return and no conventional medical treatment gets quite the same improvement? I think probably the latter. We have started looking at some of the genetics of this group of patients as well to see if there's anything there, but that's early days at the moment. So I think it's a mixture. I mean, the analogy we use often is if you've got a fly coming on your hand, you notice it. When you've got your shirt, you don't, because you're so used to having so many dips and ups, even with tight control, that once you've got that tightness, you get the awareness of it quite quickly. But I do think glucagon has a part to play, and the GLP work is starting to also show some more complicated feedback as well. So
I enjoyed your talk very much.
Okay.
I was wondering if you thought the position of the islets important in terms of orthotopic, and I know they can't be completely orthotopic, but whether being within the portal flow is important. I mean, it's certainly important for liver, and interestingly, when we do a successful multivisceral, we don't worry about the pancreas at all. It just gets on and functions.
Yeah. So I think that's been one of the dilemmas about where to put it next. So I think we're working on the assumption that you do need a component of that. And that's why we've chosen the abdominal wall for these things, because you can pick up both systemic and portal blood flow from the siting we're putting there. So I think the thing is, yes, in terms of your first part of insulin release, etc., we think that probably is important to recreate to get the optimal method. So that is why the sites that have been proposed that are completely away from that are, I think, the lower down on our list of priorities. But exactly what the outcome is, I don't know. I mean, certainly, we're getting good control there, but we know the liver is not the right place to have it in the end, not least by the fact that the toxins and things being drained in the Kupffer cells, etc., that it's not the greatest environment to keep them safe.
Yeah, has anyone looked at islet donors and screened them by family history or HLA type to see if that affects outcome?
There is a paper which has been a multi-center paper looking at some of the genetics of these, and particularly looking at some of the type 2 markers and seeing function. The early data suggests yes with the type 2 markers, but I think the jury's out at the moment on that. Okay. So I think the optimal donor, I mean, we know that the age, we've looked at BMI, we've looked at some of those other parameters. I think the genetic stuff is just coming online in terms of being able to predict a patient that may well have suboptimal function.
And then very quickly, has anyone looked at antibody titers, diabetes antibody titers, post-transplantation, and correlated that with a drop in C-peptide?
Yes, but I think the problem with islet function is that it's an all or nothing. Unlike the pancreas graft, particularly the ones that are drained in the bladder or used to be drained in the bladder, you can actually take samples of amylase, etc., etc. We really have very little marker, and we have In fact, even during the night last night, I got a phone call from one of the other centres saying they had a patient who was doing really well for 2 years, and over the last 24 hours has just suddenly changed and suddenly dropped. Now, some of those you see a response. You see autoimmunity recurrent in some of them. You see some of them you see that have had a standard rejection episode. The vast majority, however, you don't see anything. It's really unclear what exactly has happened. With a gradual deterioration, you get islet fatigue after a certain time if you had a suboptimal graft. But again, it seems to be you don't get a warning. You just really after maybe that may be slightly like a week rather than a couple of days. But you still get a sort of switch off. So yes is the answer, but it's not a clear correlation between whenever they fail, it's always that. Yeah.
I'm going to call time. Can we give a really extraordinary hand for this great guy?